Okay,
Uh,
she's here.
okay.
Okay.
So, very good afternoon, good evening, and good morning to everyone joining us today for our ACNS WIN webinar. This will be our 9th session for this year. And yeah, we've already passed the halfway mark. Nice to see a lot of familiar faces joining us today. So for start off, today our chair will be Prof. Selfie Oswari. She's the consultant neurosurgeon in the University of Pajajaran Hassan in Saidikin Hospital, Bandung, Indonesia. And she will give us a talk today and teach us on the one learning point. Together with that, we will have two speakers joining us, Dr. Nurullah and Dr. Evelyn. And today we will get the opportunity to meet a few WIN from Ukraine. That will be quite interesting. There are a few of them who are joining us today, women neurosurgeons from Ukraine. So our discussions today will be Prof. Alexandra Wozniak. He's, of course, usually joining us, chief of a neurosurgical center in clinical hospital in Ukraine. He's the president of the Ukrainian Association of Neurosurgeons. And Prof. Hidehito Kumura, which we are also all very familiar with. He's the associate professor, Department of Neurosurgery, Kobe University Graduate School of Medicine, Kobe, Japan. So without wasting much time, I will hand over this session to our chair, Prof. Selfie Oswari. Can start off with her presentation, endoscopic endonasal transclival approach, and then take over the floor to continue the webinar. Selfie?
Thank you very much, Sharon.
Yeah.
Can you hear me? Yes. I'm very sorry, but I think
The volume is very low. The volume is very low.
Hello.
The volume is very low. Can you increase the volume of your computer?
Hello.
Can you increase? We can hear you, but the volume is very low.
Okay.
Please increase the volume of your laptop.
Okay, how about now?
Yes,
Okay,
great.
good.
Okay, it's better. Okay, thank you very much, Dr. Sharon. So I apologize, but so thank you very much for Professor Kato for the opportunity. But I think I'm a bit misunderstood with the invitation. I thought that I'll just be helping Dr. Nurullah Armytasarif for her presentation. So I apologize, but I don't think I'm gonna present for this session. So I think we can just go ahead to the next speaker, Dr. Nurullah Armytasarif for the STA-MCA bypass inlet phase stroke. Dr. Sharon.
Yeah, no problem. Continue. Please continue. So Dr. Nurullah, is she online?
Yes.
So Selfie, you can continue chairing the webinar. It's okay. Because basically you will coordinate and continue with the learning points and then introduce our discussions to join in for opinions.
Sure. So Dr. Nurullah Armytasarif is our senior female neurosurgeon in Indonesia. She's one of the first, maybe actually the third female neurosurgeon from University of Indonesia. So she's currently working as a vascular neurosurgeon in one big chain hospital in Indonesia under the government. And she's very keen and dedicated, and of course, beside helping the other woman in neurosurgery, but also to expand the knowledge and also to apply the advanced vascular neurosurgery in Indonesia. I think she already done a couple of these cases, the STA-MCA bypass in late phase stroke, because in Indonesia, I think we're just starting to do bypass, and Dr. Nurullah Armita is maybe the one and only female vascular neurosurgeon currently that's doing the STA-MCA bypass. So please, Dr. Nurullah Armita, to start the presentation.
Sharon, maybe Evelyn is first. How do you think?
We can start with Evelyn first. Hi, Evelyn. Evelyn, are you there?
Yes, she's was
Yeah. Evelyn, would you like to start off first, Evelyn? As we wait for Nurullah to get her slides working. Yes. Yeah. Hi, Evelyn. Can we start off with you first? So I think Evelyn is our neurosurgeon from the National Institute of Neurological Sciences, Peru. She's been graciously attending our webinars and also doing presentations. And she's one of the very inspiring young female neurosurgeons from South America today that I see actively participating in our webinars. So today is going to present for us a microsurgical anatomy for a safe neurosurgery, posterior median sulcus, approach to a medulla oblongata cavernoma. So Evelyn, can you start?
Can you hear me?
Yes,
Yes.
we can hear you clearly.
Okay.
You see my presentation?
Yes,
Yes.
we can see clearly, Evelyn.
I need one moment. Okay. Good evening, everyone from around the world. I am truly honored to be here, and thanks the ACNS and especially Professor Yokato for this opportunity to share the work in the institute in Peru. And this map shows the place where I trained. The last month I spent one more month at Fujita Bantane Hospital training with Professor Yoko Kato, and currently I am in France with Professor Dufault learning more about awake surgery for gliomas. This is the hospitals when I work in Peru in the cities in Peru when I worked. And today I show this paper was published in May of this year. No, this article published in World Neurosurgery was based on the dissection performed in the reactivated neurosurgical laboratory on the National Institute. No, the main surgery of this case was Dr. Mao Vasquez. No, Dr. Mao Vasquez is specialized in functional neurosurgery and epilepsy. The research include Dr. Lines, who trained in school-based and endoscopy, and Dr. Saavedra, he currently the director of the institute, specialized in minimal invasive and stereotactic surgery, along these other colleagues who contribute in this paper. About this case, in this case, we present the case of the female patient in early 20s, no, who no significant family or medical history, who was admitted with acute headache associated with left side numbness, hiccups, and persistent dizziness. That's evolved over over 24 hours. In the neurological evaluation, the patient present present left hemipoesthesia, paresis of the 9, 10, and 11 left cranial nerve, and less dysmetry. On computed tomography performed on the same day, hyperdense lesion was observed on the ventricular aspect of the medulla oblongata, with no extension in the subarachno and ventricular space. In TE1 weight magnetic resonance imaging with contrast confirmed a well-circumscribed non-enhancing medullary lesion. The T2 echo gradient MRI with contrast demonstrate the blooding artifact, typical of Cavernoma formation, together with interrelational hyperintensity in T1 and associated acute bleeding was suspected. The sagittal view demonstrate the lesion presenting toward the ventricular surface adjacent of the gracile tubercle. This is the providing ideal point for surgical access. The lesion was not apparent in the vertebral artery cerebral angiogram. Shown here is supporting the diagnosis of the cavernoma, ruling out other vascular malformation. About the rationale for microsurgical treatment, the factor that favor the surgical management include the young age of the patient, the progressive nature of their clinical deterioration, and the mass effect of in the critical area. There is the potential benefit. The general risk of the cranial surgery and the specific risk for the region included quadriparesis, multiple cranial nerve deficit, the possibility of incomplete resection of the brainstem cavernoma formation, and the death. They explain the target treatment where the release mass effect on the critical brainstem, to prevent the deterioration and to improve recovery potential and eliminate the risk of further hemorrhage by carrying out the complete excision. The alternative and why not choosing this alternative. Alternative to treatment were mainly conservative management, Another surgical corridor to potential reach the lesion is by the floor of the foreventricular. However, this was ruled out as the nuclei of the 10 and 11 cranial nerve are encountered here, and the damage. This structure will result in harmful neurological sequelae. Furthermore, about the radiosurgery from brainstem cavernoma is a subject and ongoing randomized trial and was not favored in this acute setting after recent hemorrhage. This why not chosen. About any necessary equipment and experienced anesthesiologists, neurophysiologists monitoring, and surgical microscope are essential to assay to save brainstem surgery. About the position, the procedure was performed in 3/4 prono of concord position with the chest raised and flexion of the head approximately 30 degrees to break the pontomedular junction closer to the surface. This is very, very important. And the key surgical step include an standard suboccipital craniotomy, televelar dissection, posterior inferior cerebellar artery dissection, and two most relevant steps were the dissection of the posterior median sulcus and the circumferential dissection of the cavernoma. This is the case very important. This the anatomical specimen here demonstrates the relationship between the cerebellar tonsillar, the pica and gracilis tuberculous, and the cervical corridor. Now, the posterior median sulcus is the most superficial point to reach the lesion. The dissection of this allows us to expose the medial part of the gracilis tuberculum and to start the resection of the lesion and floor of the foreventriculum. Although the distal reference point was always taking, this anatomical reference were verified during the surgery. This is the correlation with the neuroanatomy. The craniotomy, linear incision was made from approximately C4 to 1 centimeter superior to the inion. The middle line is dissected without manipulation most mass, and the suboccipital craniotomy and resection C1 was performed. The durotomy was based over the transverse sinus to wide exposure the cisterna magna and ponto-medullar junction. The video is here. Okay. Once the approach was complete, arachnoid dissection was performed to release cerebrospinal fluid and improve the mobilization of the cerebellar tonsillar and posterior inferior cerebellar artery after the lower floor of the foreventricular and expose. The prominent means of the 10 cranial nerve were identified. Important landmarks were injury and could be catastrophic sequelae of the patient. These landmarks were located toward the upper and delimited the cavernoma. It saw the side of perform the resection to posterior median sulcus distal to the floor of the foreventricular approaching the lesion of the gracilis tuberculous. Here with the posterior inferior cerebellar dissection, the dissection of the posterior sulcus was craniocaudal between both prominent gracilis tuberculous. We'll monitor free electromyography the 9, 10, and 11 cranial nerve as do this circumferential dissection. The cavernoma performance using the Jasser field. The adhesion of the superior pole was in this part was. This is a circumferential, and see the was population this part for the complete resection, and the verify the hemostasis was satisfactory. Next. This is the comparison of the anatomical specimen and in the same surgery. The clinical and imaging outcome, the patient was successfully extubate, was discharged after 3 days with grade 4 left hemiparese was recovering after 2 months. No new vulvar dysfunction, and postoperative showed the complete resection. The complete resection. The magnetic resonance, this is magnetic resonance as 2-month band with confirmed. Only see the perinational hemosiderin deposited. That's resection as which is contraindicating brainstem cavernomas malformation. about the disease, the burnout, approximately 20 of the cerebral cavernomas occur on the brainstem, most frequently in the location in the pons, and middle brain lesion is 2 to 3%, and recurrent hemorrhage rate is 17 to 21%. The treatment option, the cerebral cavernomas formation, and that has bleed and are accessible in surgery, especially following repeat hemorrhage. The conclusion, the posterior median sulcus is a safe entry zone to resect the cavernoma of the medulla oblongata. This is all. Thank you very much for attending.
Thank you very much, Evelyn, for your presentation. Selfie, you can take over now for the session. Yeah, thank you.
Sure, thank you, Sharon. So thank you very much. It's a very excellent presentation, and I'm sure that it's not an approach that is common, and I don't think a lot of surgeons have the opportunity to actually expanding their skills and ability in that specific approach. So I'm sure that we have a lot of questions. I would like to open the question for all the participants. We do have one comments in the question and answer from Dr. Uday Bharti, say that it can be done with a minimal invasive approach, but however, as mentioned in the book by Dr. Charles Theo, the telovelar approach is difficult by minimal invasive technique. Would Dr. Evelyn, would you mind commenting in that matter, saying that the telovelar it's quite not an easy approach. Would you mind commenting a little bit about that? Thank you.
Yes, it's too difficult. The problem for resection is if the approach is more minimal invasive, that's the probably don't resect all the cavernoma. And with this approach, the risk is possible no resect, but the planning is to resect all the cavernoma, because if not resect all, the risk of the bleeding is major. It's possible, but that is the risk of not complete resection is major.
Okay, thank you. And while waiting for other participants, if they have any further questions, everyone can write.
Sorry,
Oh,
Selfie.
yes,
We have two cousins today, Prof. Alexander Wozniak and Prof. Kimura. Maybe you all want to give some comments. Thank you.
Professor Kimura, maybe you will be the first, or I?
Hi, okay.
Okay, I will
give you
be
a
the next,
comment.
okay.
Okay, thank you. So, thank you, Evelyn, and thank you for sharing excellent surgical technique for the fantastic, amazing surgical case. It's so nice to see that the patient suffering the surgical procedure. So hard, challenging area for the brainstem, medulla oblongata. I think that, yes, as you mentioned, as a chair mentioned, very so rare for us all, I think, but I have several comments here now. So I have one question. So did you prepare for the cardiac pacing for in this treating the brainstem region? I think that the patient is positioned prone position. So if you approach to the brainstem, may intraoperatively may suffer the cardiac arrest intraoperatively due to the medulla oblongata, the region located at the medulla oblongata. I need a cardiac pacing before the operation and instill the patient. Did you prepare? How do you think about this matter? Thank you.
about cardiac. I
Yeah.
think it's,
No.
not only the position to elevate, but not was in the not was any
Nothing
cardiac.
happened,
No.
especially good. Yeah. But I think that, yeah, more importantly, intraoperative monitoring, as I mentioned,
Yes.
MEP, of course, and SCP also, and lower cranial monitoring using yeah. Did you please mention about elaborate the intraoperative monitoring for this patient? One more, please. So, what did you do? MEP, SCP,
Yes.
all cranial nerves, lower cranial nerve monitored to this patient?
Yes, the preference of the 9, 10, and 11 was all the monitoring the
Great.
patient was.
Okay. And maybe in the dissection of the region, in the important point, we have to detect the dissection plane around in the intraparenchymal, intramedulla oblongata when you
Yes.
approach the region. So what is the important point to detect the dissection plane around inside the brainstem? Thank you.
Okay. The most important was delimitate the posterior median sulcus, because if many times the cavernoma malformation when bleeding have the possibility that the posterior median sulcus was moved.
Yeah.
And when I need to dissection very low for continue, and and in this case the limited superior was the floor of the four ventricles was the limit.
Yeah.
Start the dissection was cranial, was start to cranial to caudal.
Cranial to caudal. I think that usually we surgeon need to detect the dissection plane, watching the clearly visualize the surgical field, highly magnified inspection. So once you detect the grayish and like a yellowish plane, so it's just a change the color region. So we usually the yellowish. So we call that gliosis layer around the region. We need to detect that's like a yellowish colored. So once we detect around the region grayish normal, not normal color, we just going around the tumor dissection plane, just detecting the grayish region. So I think that it's a very important point. Even in the brainstem, we need to detect the grayish layer, not a normal color, but a little bit change the grayish plane maybe detected first. Once you detect the appropriate right dissection plane around the cavernoma, maybe the removal is not so difficult, I think, once we detect. But of course, it's so challenging in the region. Thank you. Thank you for your sharing. Yeah.
Yes. In this case, it was possible, but the problem is better than the posterior middle and sulcus. Identify, yes. But in the sagittal view, see that is the optimal area for in the and foresee the cavernoma more fast, and the yellowish color is help for circumferential section too.
Yeah. Thank you. Yeah. Very important. More importantly, the important point is to detect the most superficial point of to the region. When you open the dura and approach to the lesion. But how do you manage when you find out the tumor changed color on the surface of the brainstem? How do you do? Once you detect the color changed lesion on the brainstem, you can you can approach the lesion more easily. But how do you think about if you can't find out the lesion on the surface on the brainstem? How do you treat the patient? How do you recommend?
I think it's very important to analyze the safe entry routes, because in the old brain stems, all the space are very important and not friends. Some it's for this that they choose that this road, this safe road.
Yeah. Thank you. Thank you. So I just want to hand it to the Alexander.
Thank you,
Hand over
Professor
to the
Kimura. Thank you. I will
Alexander.
go on
Thank
with
you.
this discussion. Thank you. Really, Dr. Rojas, really interesting and controversial case. So first of all, you must be happy and patient must be happy that everything finished very well. I have one question. Did you perform the MRI tractography to the patient before surgery? Tractography? Tensor.
Yes.
Yes, it's very important in cases like this, because the direction of shifting is really important. From other hand, in my practice, I have many cases of Cavernoma of all locations. I never use midline approach for the lower medulla oblongata. Why? Because you remember, because we have a crossing of spinothalamic tracts in this area, and once you cut it, the patient will deteriorate heavily. So if I did the case, I'd use the approach via posterior lateral sulcus with using bilateral approach. It's much more safe for the patient for the case like this. Only in cases when there is a exophytic part of Cavernoma, you can use this, and I can use the approach like this. Even when on the MRI, it seems to you that the Cavernoma abuts to the surface. Don't believe it, because usually you can have 2-3 millimeters of white matter, and in this matter could be the tracts which you can damage. That is why the abuting on MRI, even on T1, it's not a sign of absolute abuting to the presence on the surface. So in this case, I'd strictly recommend to use bilateral with via posterior lateral sulcus. But fortunately, in this case, everything finished well. So that is my comment, and thank you very much. Thank you.
Okay. Thank you very much for the comment.
Thank you, Professor. I would like to again open for the participants that would like to ask questions. If not, then maybe I will just have one question to Dr. Evelyn. I think this is an impressive surgeries that I would like to congratulate you. Would you mind giving the tips and tricks on when would you choose this specific approach, like maybe based on the MRI, the tractography and everything, after the discussion that we had with our two professors? So would you mind sharing your knowledge and how you choose this approach? Like maybe if there's another Cavernomas like in different location, maybe what guides you to choose this approach? Thank you.
Can you hear me?
Yes.
Okay. Mm, this approach was we choose because the analysis the imagine and was the safe road and have all the neuromonitoring and was I think was very important to see the in the sagittal view the sagittal view and the actual view was the cavernoma bleeding and see the posterior median sulcus that's very near and not involved or the ventricular space, but very near and was very, I don't is the word, but was easy to identify the posterior median sulcus. Was for this and the team is this approach was very familiar for the team, and I think have protocol for treat the patient with approach, but many times you need to choose the better for the special patient and the imagined whether bleeding on this which was we choose, and the team do this approach very well.
Okay, thank you.
And the research on this paper was because for explain was all was good unfortunately for the patient, but the professor then say I completely agreed and have another possibility to do, but these two possibilities for a microsurgery is the best for the patient.
Okay, thank you. So I think the key is to have like a very thorough pre-operative planning and then discussing with all the team and also having all the supporting, including the interruptive monitoring available, so that you also can choose which one is the best for the team and also the patients. And I think you almost always have like an alternative or a backup if this approach cannot be continued. Okay, congratulations once again. Dr. Evelyn. Next, I would like to invite Dr. Nurullah Armita for her presentation. Is Dr. Nurullah Armita?
Yes, present. Thank you.
Okay. Okay. I'm gonna go to share screen for Dr. Nurullah Armita. Is it coming?
Not yet.
Sure, not yet.
Too big.
Yeah, we can see it now.
Yeah.
Yeah.
Okay.
Okay.
Okay, sorry for the delay. Yes, my talk is about late phase in stroke and how we deal. I'm from Pertamina Central Hospital. And most of the stroke patient in my hospital, like around this age, like around the percentage of the highest stroke risk, because it all like the ex-veteran of a company. So mostly within the age of like 65 to 70 years old, who holds like the most risk at stroke. Next slide. And the code stroke is established only recently in mid-2024 as a background, consisting of 3 neurologists and 2 neurointerventionists. Currently, patient receiving ER less than 4 hours is 73, but not all received like appropriate alteplase treatment or go directly to the cath lab for the thrombectomy because of various reasons. And about 4 to 24 hours, about 40 patients which we treated conservatively with best medical treatment. Next, please. All the 4 hours, 73 patients, 26 consist of female and 41 female. Most of the patients, male in my centers are mostly male, and mostly received non-thrombectomy. That's why I'm trying to find like some means and journal, next slide, that could like support the use of like late phase bypass. Next slide. There's not much, and it's still, I think, maybe it's like a bit 50-50 around like the benefit of STA-MCA bypass for like late phase surgery, late phase stroke. But there's some that's saying that even like the patient with high risk of arteriosclerotic disease, even with best medical therapy, still have a high risk of stroke. Therefore, STA-MCA, especially double barrel or double bypass, is proved to be helpful. And also, patient, it's different characteristic with the carotid occlusion surgery study. In new trials said like criteria for vascularization is like symptomatic cerebral-occlusive cerebrovascular disease, and also recurrent symptoms even under best medical management, which falls fit into the category of the following patients. Next slide. Last one is like STA-MCA bypass surgery improve neurological outcomes in patient with carotid terminal occlusion and also middle cerebral artery occlusion. Next slide. Well, I'm just like giving a case of patients that like fall under the category when the code strokes start. The case one is 65-year-old male admitted to emergency room with the weakness of left upper and lower extremity, about admittance, the strength is 3. And then improve of the weakness on 4 with still low paralysis of the 7 and 12 cranial nerve. He has uncontrolled diabetes and modified Rankin score was 3. He undergone a digital subtraction angiography, resulting there's a stenosis of anteterminal more than 50%. He was still on the up for surgery of any kind of treatment, then put on best medical therapy, and then he asked to go home. But then his weakness deteriorate from 3 to 2 at the distal his lower extremity, and also 4 to 3. Also, he developed aphasia, and also progressing curse of the 7th and 12th nerve. Then he agreed, and then we put him on the preparation to proceed to bypass surgery. Next slide. There's an acute infarct on the right corner radiata and centrum semiovalid dextra. Next. The diagnostic shows like stenosis at the terminal end. Next slide. We proceed to double bypass STA-MCA. Post-operation, he is clinically stable and was discharged 7 days post-surgery. Upon discharge, patient was given aspirin 80 mg, while low-dose heparin. We maintain it for some times. And 1 month follow-up, there is an improvement of aphasia, and 3 months follow-up, weakness at his feet improved to 4, but weakness at the upper extremity improved at proximal end to 3. Next slide. Okay, that was the pre-operative imaging, and the post one. There's slight improvement. Next slide. The case 2, this is like a pretty hard one to make a decision to do the bypass because it's 80-year-old male admitted with weakness on the right extremity. 1 day prior, along with speech disturbance. And patient was given the antiplatelet before and put to ICU because, of course, as an elderly, he has like other condition like pneumonia, but there's no related illness like diabetes or hypertension noted. MRI showed vast acute infarct left corner radiata and multiple acute infarct left frontal, hippocampus, global pallidus. MRI showed stenosis also of the M2 segment. Next slide. And there's like, even like overall, he's like hypoperfusion, but the one at the occlusion of the M2 showed the worst. Next slide. This is like the angiography finding from the digital subtraction angiography. Next slide. Double barrel bypass, even though I wasn't sure because from the angiography, the donor was like, seems to be quite small. And then also upon discharge, patient was given aspirin 80 milligram. Patient was a bit prolonged in hospitalization because of recurring pneumonia. 1 month after, only the aphasia and speech disturbance that improved, but the weakness is not. Next slide. This is like the angiography post bypass. Next slide. Okay, it's like this is like something that I'd like to like be a review of what I'm doing. Preparation preoperatively, usually assessment of condition, of course, because most patient is like from stroke. We give a double antiplatelet 1 or 2 weeks prior, and then 3 days prior we give like a single antiplatelet, and we stop 1 night before surgery and continue again day post surgery. The positioning is patient is placed in supine position, hex fixated, elevated above the heart, turn to contralateral sides, keeping the operative field as horizontal as possible. Next slide. Incision, superficial temporal artery. Usually, if we can, we check it from the angiography, and then afterwards we put a Doppler detector to identify the, especially the branch, the anterior branch was preferred for use in anastomosis, and trace from the anterior to the pinna to the most distal portion. Sometimes we cannot identify so much as a linear continuously, so like we try to like make it like some dots around the one that's visible. Usually we try to go for 8 to 10 centimeter, but sometimes hard. And then a direct incision was made over the STA. We use fish hook for dissection because I think that helps to make the vessels more upper and also to have like a more control. So lots of fish hook. And the incision was extended posteriorly from the pinna above the ear in the occipital side, making a V around the, like a V incision. The flap and then reflected and retracted superiorly. Next slide. The craniotomy is like depending on where you're going, usually still around the paternal area, and depending on like which recipient that you're going to after. Next slide. Dural opening, it's like Y fashion, usually depending on the location of the M4. Ideal recipient, usually located at the surface, straight, no side branches, and the largest one, length around 1 to 1.5 centimeter. Usually, if it's the older it is, the more difficult to get the ideal location for the recipient vessel. Next slide. And arachnoid dissection is doing in such manner. Dissection of arachnoids branch side, we coagulate some of the side branches, but usually not more than 2 or 3, and cauterized and cut. And then a small rubber with high visibility is usually put under the vessel as the background. And papaferrin is intermittently instilled. Because we don't have papaferrin, so we use a modification one, the one that is shared by my colleague from the National Brain Center using nimodipine and some other mixture. And the STA is then flushed with heparin saline. Next slide. Then the distance between the artery measured and allow about 2 centimeter redundancy in order to ease flipping so it wouldn't be too tight. And then also the distal end of the STA is cleared of the adventitia. So you like undermine the adventitia over like 1 to 2 centimeter. Be careful not to overdo it so we don't have like a too thin vessel. And be careful also while doing this with the forceps as not to damage the donor. They then cut in a sharp angle and fish mouth it in order to obtain opening that at least twice the diameter of the recipient artery. And then keeping the operating field clear from CSF and blood by continuous suction. We usually use like a small gastric tube, which we then connect with the suction to provide some of like small continuous suctioning. The recipient bench is now clamped on the bone side, and then we perform atraurotomy, and then also we flush it with the heparin saline. And then we're using a 10 microsuture with 2 anchoring vessel fed, and then suturing as such as manner, like from all the side until we go to the middle of each side. And we use interrupted suturing. Next slide. Once suturing is complete, flow is restored, we put out the clamp. Oozing is controlled by placing usually a small hemostatic sponge locally, no compression. And then we test it by Indocyanine green fluorescence. Next slide. And surgical closure, of course, what to mind is not to put any pressure over the STA. So actually the dura should be loose around that side. The bone is fixated, but usually have to be sufficient opening for that. And when we stitch the temporalis muscle, also like checking if it's compressing the STA or not. We don't use strain. And then also for dressing, you use non-circumferential. So and then with caution, if the hospital, like my hospital, is not used to having this kind of procedure yet, to not have no compression over the bandage. And post-operatively, we still give like an aspirin, like low dose aspirin, like 80 milligram. And first night we monitored in ICU for close monitoring of neurological and hematological parameters. And then blood pressure control to prevent hypertension, at the risk of graft thrombosis or hypertension, and the risk of hyperperfusion, which what we should watch out in these kind of cases. And graft patency can be checked by ultrasound while avoiding compression on the graft. And that is like basically what we're doing at the center right now. I think that's the end of my slide. Thank you all.
Okay, thank you very much, Dr. Nurullah, for a very thorough step-by-step presentation. And I would like to invite all participants that has questioned. You can write your question in the question and answer box, or you can also raise your hand. As a start, I would like to invite our discussant, Professor Alexander Wozniak and Professor Hidehito Kimura, to give comments.
Professor Kimura, maybe you will be the
Okay.
first again.
Okay, thank you, Dr. Nurullah, sharing fantastic surgical techniques in the suturing STA-MCA bypass. And yeah, so congratulations on your successful training after your, I think you have, you did so many training to do this kind of bypass surgery. So nice techniques. So wonderful, I think. And I have several questions here now. And the first question is, how do you manage to control bleeding intraoperatively? Because I think that the patient patients have been already given dual antiplatelet drugs before STA-MCA bypass. In this bypass surgery, it's very important to achieve the good hemostasis in the surgical field, needless to say. But in the patient given already dual antiplatelet drug, as we mentioned in a presentation, I think that control the hemostasis, control the oozing, maybe is very sometimes difficult to make a clear surgical field, bloodless surgical field. How do you manage this problem? For me, usually I just have only one single antiplatelet drug, not a dual antiplatelet drug, to control to avoid the bleeding. So how do you think about? Thank you.
Yes, true. Like the patient was mostly already on best medical therapy, so has history of double antiplatelet. But when we perform like a surgery, we stop the double antiplatelet and just continue like the single antiplatelet for 3 days. And one night prior, we're not giving any antiplatelet. But yes, on the opening, we do have like such a thorough hemostasis for like the oozing, especially when the opening. Yes, that is like a bit of problem. And there's like in one patient, there's like a subdural postoperatively, but luckily not that significant. But yes, that's happened. And it's just like a theory, but maybe because we never check the PYG, the one to test like, are you is like the drug is working for you or not. So maybe in the patient that currently I'm working, that dose and the clopidogrel is not sensitive. So
Yes.
that might be one of the things that helps. But I agree in this, the hemostasis is in patient is a problem, and subdural postoperative did happen.
So I think, yes, clopidogrel is a very harmful, awful drug for surgeons. Maybe we should discontinue at least more than not 1 week, 3 days. I think the 2 weeks needed to delete the drug efficative antiplatelet drug efficacy. Yes, I think that more than 2 weeks we should discontinue clopidogrel when you use. But I think the patient originally suffering the hemodynamic insufficiency, as you know, for this kind of disease. Not I don't need. I think we don't use the dual antiplatelet drug. Only single is maybe insufficient for this kind of patient. I think not the dual antiplatelet drug. But yes, of course, in case that it's okay. Of course, a dual antiplatelet drug. Maybe I think, but. Yes, I just recommend to use a single. Yeah, more.
If like for single, do you recommend the aspirin only then?
Yes, aspirin.
Milligram or 100?
100.
80 or 100? 100.
I think 100. Yeah, is insufficient. Yes, not 300, 200. 100. Okay, just aspirin. Yeah, not a clopidogrel, I think.
Okay.
But so please for me my second question. So I think that in Asian countries, you may encounter the moya disease patient in the stroke patient. But do you encounter the moya disease in your patient in stroke disease?
The thing is like moya disease, we never encounter like before it bleeds, but after it bleeds and it's a young patient with prior no history of illness, we do. And then repeatedly, we do the angiography, and then it's encountered. But because my center mostly have like elderly patient, so it's like encounter in my colleagues. I know it from my colleague center, but we do have it at the other center, but not encounter at my center.
Yeah, I agree, but I understand. But sometimes only for the adult patient, even in the adult patient, of course, we sometimes encounter the intracranial hemorrhage, interventricular hemorrhage in the moya patient usually suffering such kind of intracranial hemorrhage. So I think, yeah.
Do angiography still?
Yes.
Okay.
Do you need to technical change for the moya disease? Do you have some opinion for this kind of moya disease in the adult patient, not for the atherosclerotic disease patient? Do you have some comment, different technique for the moya disease? If you have, I think.
I don't. I'm sorry, but like I said, like I have no like diagnostic of like moya disease that is
Okay, thank you.
confirmed diagnosed at my center. So I have no expertise to comment on
Okay,
that.
thank you. Thank you. Please, Professor Alexander, do you have some comment?
Thank you,
Thank you.
Professor Nimur. I think I will go on. Dr. Nurullah, thank you very much for really academic and informative and well done presentation. First of all, I want to say that the STA-MCA bypass it will always attract the neurosurgeons because of its elegance of this surgery, even besides of even when maybe the evidence of its effectiveness is not so high, but anyway, we will go on to do it and to believe, once we believe in this procedure, it will benefit for the patients in majority of cases. That is why your enthusiasm is, I absolutely support your enthusiasm and wish you to go on with this activity. Of course, the patients with tandem occlusion, with distal occlusion are the good candidates for surgery like this. Maybe there is some controversials about the surgery, but anyway, I support you in this activity because there is nothing to lose for this patient, and you give them the chance by this surgery, and I saw they are very well investigated and selected, and indication, I think absolutely obvious indication for the surgery. I have only one question. Maybe I missed. I saw the post-op angiograms, but did you perform the perfusion investigation after surgery? And did you prove the improvement of this zone of ischemic zone?
Not
Yes?
all, not all. I perform like MRI perfusion, depending of like they could do it or not. But for the very old patient, which I did like the 80-year-old, the improvement is like not so much because the before is like already very dark, and maybe
But
it proof or
but
not, but
I
the
recommend you will complete this job. It will be more presentable because I more than believe that you will have as you had the perfusion before. So I'd recommend you to perform it after, and you will prove that you were right that you performed this procedure.
I will when
And
the patient
final,
checking
my
back to me.
congratulations. Thank you for a great presentation. Thank you.
Thank you.
Thank you very much, professors, for your excellent comment and also adding on the expertise of Dr. Nurullah Armytasarif as one of the pioneer in the women neurosurgery that actually performs this procedure in Indonesia. So we actually have one question in the question and answer box. Did you consider the option of stenting procedure for the MCA stenosis?
Yes, I consider it if like there's like no vessel and if like the location is like sufficient for the stenting, depending on the which part of the MCA. So like, is there any branch coming out of there? And the position, is it like susceptible for stenting, like for like terminal? Because of the position, I'm not favoring of putting a stent in there for the case that I present.
So I think the follow-up would be, when would you choose this procedure, the bypass, over the stenting for the MCA stenosis?
Depending of like the degree of stenosis, because like for like a severe degree of stenosis, there is a risk of like rupture for stenting, and also is there any outgoing branches coming out from the vessel, and also like the location is like, and the bifurcation or not, is it like susceptible for the stenting? Because in the terminal, putting the stenting there is not really feasible.
Okay, thank you. And if there's any question from the participants, I saw
Yes,
that
one
Yes,
question from Radhika.
Yes, I will ask. First of all,
Yes, Raj.
congratulations for this wonderful presentation. Just one question. What was your mean occlusion time for bypass?
Sorry, main
What
main
was the
occlusion. How
mean
long how long
Occlusion time.
Yes,
how long I clamped it?
yes.
Well, it's supposed to be like open and out like around like after like 3 to 7 minutes, but yeah, or open and out, but yeah, around that time, around the
Okay.
timing.
7 minutes is excellent time, I must say.
3 to 7 minute round, but and then
Because Professor Shubin has the
7
world
minutes.
record and his best time
No,
is
I'm
5
sorry.
minutes
Like
34 seconds.
no, it's like before if I haven't done because I'm new, of course, like it took a very long for me to stitch. It's like I just like I put it in a clip and then redo again like that. It's still in the first beginning.
Okay, thank you.
Okay, thank you very much, Raja. And I would like to invite our esteemed professor, Professor Kato, to give her opinion to Dr. Nurullah presentation. Please, Professor Kato.
Okay, thank you so much. So I heard 2 presentations, both are very nice. Recently in Japan, we have so many endoscopic removal of the cavernoma in the posterior fossa especially, because we can see very clearly and the magnification, the high illumination. And also maybe the posterior fossa is very far from the surface, I think. So maybe some of you, I think you can use to use the endoscope. That is one of the options. Evelyn, thank you very much for a nice presentation. And also the Nurullah is a nice presentation, but we need more video. So that is just a textbook. So maybe if you want to teach the younger generation, maybe you can show them the step by step, like video is very good. And also, Kimura Sensei, he mentioned already, many of the Japanese institute, we before surgery, we can estimate, maybe we can suggest which the receiver of the MCA the vessel, the best receiver of the MCA vessel we can estimate, and also the very tiny opening in the surgical field, because we already target which vessel is a good receiver as MCA, and the target the surgery is very important. So no need such a huge craniotomy and huge surgical incision, I think. And also the mostly he mentioned about some perfusion, because you can check the before and after the perfusion. How improve of the area where you put the and a small system. It's very important. Usually the occlusion time is 20 minutes. Less than 20 minutes is the best time, I think. 7 minutes is too short, I think. Anyway, thank you very much for the both lectures. ありがとうございました. Thank you.
Thank you
Thank you.
very much.
Okay, thank
Please
you
share.
very much, Prof. Selvi, for sharing this session. Before we go on, we have today introduction of our fellow women in neurosurgery in Ukraine. We have a few of them here today to introduce themselves. Are you all online? I think we have a few. So today I will start off first.
Yes.
Okay, all right. Thank you very much. So today I'll start off with Dr. Kutz Kaprenko Victoriala. Welcome to our WIN session today, and please introduce yourselves. If you have a PowerPoint share, please share it so that we can get to know you better.
Good afternoon and good evening, colleagues. I will share my presentation. Thank you for the opportunity for Ukrainian doctors to join you today. Thank you for the great presentation today. A moment, please. Can you see my presentation?
Yes.
Yes, so my name is Victoria Kutskarpenko. I am a neurosurgeon from Lviv, Ukraine. So I finished the Danilo Halevsky Lviv National Medical University in my city. It's 6 years of study. And then I moved to residency of neurosurgery. It's 3 years in Ukraine. It took 3 years in Ukraine. Now it's 6. I undergo my residency in Lviv Emergency Hospital, and also I was practice in Neurosurgery Institute in Kiev. And during my residency, I undergo some study in Belgium. It was like cadaver study for endoscopic approaches, and also a few fellowships in Warsaw, Poland, and Germany. And military neurosurgery, I studied it in Dnipro. It's east in Ukraine. It's very important for Ukrainian neurosurgery. Also, my favorite is a winter seminar in Japan. I hope I will come back soon. So my work experience now, I'm working in Lviv Fast Medical Union in Lviv, Ukraine, and also in Ministry of Health. I'm helping with medical evacuation program for our soldier. And during my student years, it was a lot of volunteering and scholarships. First of them, it's Ukrainian Medical Student Association, and also I'm founder of Medical Mentor organization. It's to help some student and resident and to find their mentors, because it's really hard sometimes. And I am concentrate on endoscopic neurosurgery, skull-based neurosurgery, also practice in oncological neurosurgery, and I would like to develop my skills in open surgical intervention for cerebrovascular pathologies. Thank you so much for supporting us, for supporting Ukraine.
Thank you very much, Victoria. Now we will call on the second woman in from Ukraine. Can we have Daria Chikunova? Is Daria Chikunova around?
Yes, I'm sorry. Two of us cannot join us today.
It's all right. It's all right. It's all right. So yeah. Tatiana, maybe you can go ahead and introduce.
Yes, of course.
And then Nadia, you can go ahead and introduce yourself after that. Okay, great. Okay, come on.
Yeah. So I will share the presentation for Tatiana.
Thank you. Thank you. Good day, dear colleagues. My name is Tatiana Statsenko, and I also I work as a neurosurgeon at the Lviv Regional Hospital for War Veterans and Victims of Repression, named after Yuri Lipa. It is a real privilege for me to be here today and to join this inspiring community of women neurosurgeons. Let me briefly tell you about my professional path. I started my studies at Dnipro State Medical University and later continued my medical education at Danilo Halevsky Lviv National Medical University, where I graduated in 2019. After that, I entered residency in neurosurgery at the Dnipropetrovsk Regional Clinical Hospital, named after Ilya Mechnikov, which I completed in 2022. I also took part in several specialized courses. In 2024, I trained in peripheral nerve injury surgery at the Ramadanov Neurosurgery Institute in Kiev, and in advanced microscopic surgery using the 4K 3D exoscope at the National Cancer Institute in Kiev. Most recently, in 2025, I attended a thematic school on the basic principle of neurotrauma treatment organized by the Global Medical Knowledge Alliance. This year has also been very important for me.
as I began my fellowship experience in 2025 on April, I joined the main clinical medical center of the Minister of Internal Affairs of Ukraine, where I practice in the Department of Reconstruction Microsurgery in Orthopedics. I also started a fellowship at the Gomez Ulna Defense Central Hospital, Spain. I worked in the neurosurgical department. My main clinical interest today includes cranial reconstructive surgery, where I continue to develop my skill. I am also depending my practice in microsurgical neurosurgery and in peripheral nerve neurosurgery. Looking ahead, I would like to expand my expertise and gain new knowledge in vascular neurosurgery. Thank you very much for your attention. I'm truly grateful to share my story here, and I look forward to learning from your experiences as well. Thank you so much.
Okay, thank you so much, Tatiana. So finally, we'll have Nadia Balkovich. Nadia, would you present your PowerPoint?
Hi, everybody. Yes, I have a little presentation. Thank you so much for your attention. Thank you so much for supporting Ukraine, and especially women neurosurgeons in Ukraine. We really appreciate it. Thank you so much. One second, please. I'm trying to share with my presentation. Do you see that? No?
Yes. Yeah. No, we don't.
Do you see my presentation?
No.
One moment, please. Sorry, I cannot share with my presentation. Okay, I will present myself without my presentation. I will start to do not spend your time. My name is Nadia Balkovich. I'm a pediatric neurosurgeon. Now I live in Ukraine, but I born and lived in Donetsk, wonderful Ukrainian city, which now is under occupation. I was study and in Donetsk National Medical University, and I complete my residency in neurosurgery in 2011. Then I continued my practice as a pediatric neurosurgeon. The first years of my neurosurgical practice was in Donetsk. I was focused in pediatric neurosurgeon and especially in neonate neurosurgeon. I was involved in it. So we organized a lot of departure of neurosurgical team in different maternity hospitals and perinatal center. After the beginning of occupation by terrorist state, our city, I relocate in Kiev, where I continued work in Kiev Pediatric Neurosurgeon Center as a pediatric neurosurgeon. I was working with all emergencies in neurosurgery and, of course, traumatic brain injury, emergency surgery at all. Then in 2019, 2091. I was working in National Children's Hospital, Ahmadid. The main direction there was neuro-oncology. And now I'm working in Kyiv City Perinatal Center, and also I'm working in Kyiv City Pediatric Hospital number 2. The main directions are neonatal neurosurgery, congenital CNS malformation, of course, pediatric neuro-oncology, and of course, wartime emergency care. Now, I am on duty, as you can see, I'm in hospital, and in an hour, I'm going to operate one small baby who suffered because of missile attack. Baby was born premature, and now she has a progressive hydrocephaly after intraventricular bleeding. So this is the main direction of my activity. I have 4 children. They are, as I think, they are my main achievements. My family, because they give me a resource, and I can give this resource to other children. This is my position. So thank you so much. I really apologize that I cannot show you my presentation. I wish you have a good day, and thank you for everything that you're doing for us. Thank you.
Thank you very much, Nadia. I think I'll now hand over to Abida Shah so that she can take over. And also,
I'm sorry, we have one more.
I know. So Abida is going to introduce her. Don't worry, we haven't forgotten Rusana. Yes, Rusana, right? One more.
Yes.
So
Right.
thank you. And now we invite Dr. Kukenko Rusana to give her introduction.
Yes, I look me.
Yes.
I am presentation.
Yes, we can see. Go ahead.
Okay. Good afternoon, good day, dear colleagues. I am a neurosurgeon, Rusana Kukenko, currently working in Ukraine. Next slide. I was born in Melitopol, Zaporizhzhia region in Ukraine. Now currently working in Ukraine, now the occupied territory. After I graduated from school, I studied at the medical university, Vinnytsia National Medical University, name of Pyrgov, Ukraine, Vinnytsia, graduated 2021. After graduated university, I'm from university entered internship in neurosurgery at the Sulcus National University of Healthcare, Kyiv in Ukraine. I was trained. Next slide. I was trained at the base scientific and practical center of endovascular narrow air X-ray surgery in Kyiv and Ramadanova neurosurgery department of endoscopic and craniofacial neurosurgery with a group of adjuvant treatment. The practice training base was at the Zaporizhzhia Region Clinic Hospital, Zaporizhzhia, Ukraine. While I was training in Zaporizhzhia, the war broke out and Zaporizhzhia became a frontline location. There was a lot of practice and with mine and explosive injuries. Several cases. Next slide. You look several cases in my practice. Ward rooms. Next slide. Perform surgical treatment of military trauma on the central nervous system, mine and explosive and bird wounds, plastic surgery of durometer, defect after shaper and broad wounds with fascia. Skin flap plastic surgery with skin flap defects. Next slide. Providing assistance to the release from captivity or vertebral fractures with lieutenants of neurological defect. Minor explosive injury to the neck with damage to carotid artery. Functional neurosurgery internship. I have separate regional clinics. You have stereotaxis biopsy and globus pallidum simulation Parkinson disease. Next slide. Removal of hemiductor from the bifurcation of the common carotid artery. Next slide. I have endovascular practice internship in Lviv 2024 years. Is this several cases in example presentation. In 2024, I completed internship in specialization pediatric neurosurgery. In 2025, I have internship and radiology in Shupikal National University of Healthcare, Kiev, Ukraine. Volunteering in Frida, Ukraine mission, Ukraine Israel mission, volunteer missions, and development skills in oncology and vascular neurosurgery. Mastering the skills of clipping brain aneurysm, dependency in the removal of craniofacial tumors, development use skills in open surgical, interventional, and cerebral pathologies. Thank you for your attention.
Thank you, Rosanna. And it was very nice to have the WIN of Ukraine with us, sharing their workplace, their passions, and their neurosurgery. I would like to invite Professor Wozniak to give a few words of encouragement to the WIN Ukraine members.
Thank you. Thank you, Professor Shak. Thank you, Professor Kato. It's my pleasure to see presentation of my younger colleagues, actually, women in neurosurgery, girls in neurosurgery. And I'm really happy that Professor Kato initiated this movement, this event, and I called some our girls in neurosurgery, and you know that they with pleasure decided to create a group inside of association. And from my side, I supported it as much as I could, and will support them in future. And so as the final, I'd like to express again my gratitude, and I hope that this movement will bring the results in nearest future, because I saw that our women are very enthusiastic and they're ready to organize a lot, and they are able to work hard for education and for development. So it's a very good beginning, very good initiative, and I wish the prosperity of this initiative. And another, it's my pleasure that point out that they joined the World Organization of Women in Neurosurgery. So my congratulations and thank you.
Thank you very much. Abi, would you like to have any comments, Abi? Or we let
No, I think we had a good webinar with two good technical presentations. The first one on the brainstem approach to the cavernoma. So my comments on that is the brainstem is riddled with white fiber tracts. So we have to find the best way to get in. The easiest way is to see where it is pointing and then going through that approach. A lateral approach is always more safer than a midline or an anterior approach. That is one of the basic things you must remember. And for the second presentation, the STA-MCA bypass, though it is a little bit controversial, it is nice to see that people are trying to come up with new strategies to deal with stroke and how to revascularize the affected brain. So we had very nice presentations and nice introduction to the WIN of Ukraine. Before I end this webinar, I would like to invite you all for the ACNS, the 15th ACNS. Can you see my screen, Sharon?
Yes, we can.
So the 15th ACNS, which we'll be hosting in Mumbai next year from 31st July to 3rd August. It's right in the center of the city. And we will have a lot of pre-conference workshops with the young neurosurgeon sessions. And then, of course, the main meeting. I would like to invite all of you to join us for this meeting. And I would like to also encourage all the WIN members to participate. I will be sending you out flyers and we will try to support the young neurosurgeons how much ever we can. Thank you. Thank you, Sharon, and thank you, Professor Kato.
Thank you. Thank you, Vida.
Before we close, Alexander, is it possible for the younger the women neurosurgeons from Ukraine can join maybe 3-4 days in Mumbai?
I think we will support it. We will discuss it with Victoria and her team already. So I think we will support. You know, we support our young neurosurgeons. We support them with some financial support also when they go to study in Europe, in European course. Maybe we will support this activity also. Okay, we will discuss it. Okay, Victoria, yes? Yeah.
Yeah. Victoria,
Yes,
maybe
I agree. It's totally possible, so we will try to do it. Thank you.
Great.
I think you can share or you can exchange your knowledge or skill among the world people. I think it's very, very important.
Thank you.
Not only
Thank
in
you.
the Ukraine.
We will do, definitely we will do it.
Yeah, thanks.
So I think, thank you so much. I think like what Abida said, just to sum it up, we had two interesting presentations. Evelyn, thank you always for willing to present. And I think like one of the take home messages was the timing of the surgery is very important. All right. I think cavernomas, when we see cavernomas, the best is to actually treat the ones that have bled and also wait for the right timing. So we get that hemosiderin ring, and that helps us, like I think what Prof. Kimura was trying to explain, to help us to excise the tumor. And Nurullah, thank you so much for a very interesting take on STA-MCA bypass, which I think it is quite controversial. So maybe you can do a better study on that and then give us your final thoughts on it maybe a year from now after, comparing cases and things like that. It would be good, Nurullah, since you have the opportunity to do it there. And to the WIN Ukraine, thank you so much for joining us. Thank you to Prof. Wozniak for actually reaching out to us and sharing their names and their contacts. We are so happy for you all to join us. We hope in the future we can invite you all to actually join us in our webinars and actually present your experience, some topics. I see that you all have very interesting trauma topics, which I think a lot of us don't see anymore. So Rosanna, you presented a lot of, things that I maybe saw it when I was back in, training where we do a lot of trauma, but I don't think as interesting as what you can share with us. So it would be good. I think sometimes it's good for us. We all should remember that trauma is the bread and butter of neurosurgery. So it'll be great to go back and have a bit of experience on that side. So maybe in the future we could have a webinar where you all can present on your experiences. Thank you very much. It's very nice to see ladies doing this kind of work. Yeah, it's very inspiring. Prof. Kato, any last words before I close?
Yes, just maybe I think one learning point by the selfie is the next time, I think.
Yes.
Selfie. It's just do this.
Yes.
Join us
Okay.
the webinars and to come, and then you can give us a very.
But
Thank you, everyone. Thank you, everyone.
One guy from I think Afghanistan, the professor
Professor
Fawad.
Fahd, do you want to say anything? Yeah, Professor Fahd, maybe.
Salam
Hello.
alaikum.
Hello.
Salam alaikum. Greeting. Thank you.
Walaikum
Thank you
salam.
very much. It was very good and successful webinars, and it's very optimistic about women in neurosurgery, and we're proud of you. Unfortunately, in Afghanistan, the women works are limited and prohibited, and education, unfortunately, it's prohibited now by our governments. Wish one day and hope we find a way to for education and more professional studies for our women and girls. Thank you.
Thank you, Professor
Thank
Fahd.
you.
Okay.
Thank you very much.
All right.
So see you next time.
Yes. So
Is it
thank you
okay?
very much, everyone. Yeah.
Okay.
Good night, and see you all in a
Thank you.
month.
Bye-bye.
Okay.
Thank
And
you.
have a
I'll see you.